Hello everybody and welcome to the King's Fund and to today's webinar. We're going to be talking about some of the improvements that have been made in the Canterbury health system in New Zealand and thinking about what we can learn in England for how the NHS might be able to improve care. My name's Anna Charles. I'm a Senior Policy Advisor here at the King's Fund and I'm delighted to be joined today by Vince Barry and David Mates from Canterbury in New Zealand and by Colin Henderson from Orion Health in London. And I'm just going to ask each of our guests to introduce themselves, if that's okay.
Thanks, Anna. So I'm Vince Barry, Chief Executive of Pegasus Health. And in the British context, that's a federation with quite a significant support capability. We support about 100 general practices and about 450,000 patients across the Canterbury region.
Hi, Anna. I'm David Mates, Chief Executive of the Canterbury District Health Board and also Chief Executive of the West Coast District Health Board. And the District Health Board, in our health context, is the main planner and funder of health services for a defined population. And in the Canterbury context, it's for about 558,000 population. We're also an owner and operator of some of the health system and, again, the main funder within the Canterbury health system.
And I'm Colin Henderson, so I'm the EMEA Vice President for Orion Health. We're a software company. We see our role as sewing the health system together from an information perspective. And I guess the tie to the guys from New Zealand is we're a New Zealand company, but we've also been working with Canterbury on their shared care record and an innovation programme to help with the IT part of transformation.
Great. Well, thank you all and thanks for joining us. I think today will be a really interesting conversation and I hope our online audience will get a lot out of it. So why are we doing this webinar at the King's Fund? Well, we've written quite a lot about what David, Vince and their colleagues have done in Canterbury, New Zealand. And we see quite a lot of similarities around what they've done, particularly around integrating care and working together better as a system. And what we're looking to do here in England around working together better as systems. So across the country, we're seeing local health and care systems working together through sustainability and transformation partnerships, and in some areas through developing accountable care systems. Essentially, that means different health and care organisations coming together and working together to deliver care for a defined population and to take responsibility together for the outcomes and costs of that care. So today's our chance to hear directly from the people who have led and implemented the changes in Canterbury and to hear their reflections on what we might be able to learn from their experience. Just before we get into the questions, I want to say a little bit about how today is going to work. So we've got about an hour. I'm going to start off by asking some questions to David, Vince and Colin to set the scene, to set the context, but we're going to use most of the time to take questions from our online audience. So you should see at the bottom of your screen that there's a box where you can type in your comments and your questions. So please start sending them in early, start sending them in frequently. I'll be able to see them on a screen that I've got in front of me and I will then ask the questions as they come through to our guests. So I think we're probably about ready to get started. So I just wondered, David, if you could start us off. For anyone who's watching who doesn't know much about what's happened in Canterbury, could you give us a very brief overview of what you've done and why you did it?
Well, Canterbury back in 2007 was a really fragmented, disjointed health system. We had hundreds of organisations, all attempting to do the right thing through their perspective, but often working or battling against each other. People really hard working, but we had problems across the system started to get pushed from one part of the health system to the other. We also had a long period in the early 2000s of hospitals being in gridlock, of fiscal problems across the health system, and also a sense of actually if only the other part of the health system would sort itself out, it would solve the other problems. So we were an exemplar of how not to do it, but really well-meaning people. And I think the real trigger point was in 2006, where 5,000 patients that had been referred from general practice to the hospital part of the system were dumped straight back into general practice. And it was the 5,000 just happened to be the last 5,000 referred. No prioritisation, just straight back to general practice. And I guess the beginning part of a sense of we've got to do something better than this, and our communities deserve a lot more. And I think that was the beginning part of a journey that was about starting to create a shared sense of purpose, a shared sense of what is it a health system is trying to do. And interesting enough, while we talk about a health system, at that particular point, no one had a sense they were part of a system. There were organisations, and within that there were professional silos and barriers. And there wasn't that sense of they were all part of something greater, and that actually together we might be able to make a difference to a community. So that was the beginning part of our journey in terms of we had a burning platform, something needed to be done differently. And that began the sense of creating a shared sense of purpose that was actually about the citizen, the patient at the centre, is actually what a health system should be about. And a system that was connected, one that was actually centred around people and aimed not to waste their time. And that came about from the engagement of over a number of years, thousands of clinicians and thousands of community having a sense of starting to describe what a health system could and should look like. So that was the beginning part of our journey, and over the last 9 years, it has now just become a way of working. We, like many other health systems, we talk about one health system, one budget. We're neither one health system nor one budget. We've got lots of organisations, hundreds of small businesses, for-profits, not-for-profits, public and private, local councils and territorial authorities, police and education. And what we've managed to do is, again, through a process of engagement and connecting all of those parties together, have now got people with a sense of there is one health system and we're part of it. And in that is now the collective ownership to make sure that whatever we're doing it for the patient. And a really simple mantra that now sits in our health system is really no wait, no harm, no wastage.
That's great. Thank you, David. And Vince, I know you bring us the sort of primary care perspective from Canterbury. Are you able to just tell us a bit about how primary care has been an important part of that journey and what the role's been?
Yeah, I mean, there's a recognition, as the audience will understand, that to have a functional integrated health system, you need a well-organised general practice, primary care and community-connected system to be able to support whole system integration. There's been a long history of organised general practice in Canterbury, and it started off in the late 80s, early 90s, and that was primarily around organised after-hours care, where the cooperative of GPs felt that it was going to be better if they could share their after-hours arrangements. And very much that started to build a momentum from sort of a very individual competitive environment to one that started to build a baseline of collaboration. So through the 90s and early 2000s, that carried on through a number of opportunities around budget holding. But it meant that the general practice system was still a silo. And it really wasn't until the mid to late 2000s where the opportunity was to launch off that platform as part of an integrated system. And the opportunity that Pegasus as an organised general practice system made a commitment that it needed to be a part of the Canterbury solution, as opposed to feeling like it was the Canterbury solution. And that was part of that journey. And the rest of it, I think we'll talk about over the next 20 or 30 minutes. The opportunity that's been created with working very closely with the District Health Board. And we often talk about, my job is Chief Executive of Pegasus Health, but I work for the Canterbury Health System. And you'll hear that wherever you go in the health system.
And thinking particularly about how primary care was then able to work better with other parts of the system, so secondary care. I think we've heard from Canterbury previously around the Health Pathways programme. Could you tell us how that works?
Yeah, so I mean, as David just commented, that terrible situation in the mid-2000s where we returned 5,000 people back to general practice as part of a waitlist management program and to meet a target, we recognised that in fact the referral patterns and the information that was available to general practice and to patients and ultimately to the secondary care system was just inappropriate. It was insufficient. And so we used the relationship that had already been developed around primary care and how they'd worked to start working with the secondary care system. And this is clinicians sitting in rooms together, solving problems around the pathways for patients into the system, and most especially orientating that towards actually what's the capability and the resources that in Canterbury. So very localised health pathways, and I'm sure a number of your audience are aware of the Canterbury Health Pathways program, but the pathway itself, the real gold dust in that was the relationship that's been built with clinicians, sitting around the same desks and the same tables, having conversations about what was right for patients. And so it built relationships, it built strength, and it built commitment to attend to the other problems that we've seen and addressed in the last sort of 10 years.
And so, David, you've obviously got those health pathways in place now in Canterbury. I know you also work in another district health board. Has that been something you've been able to lift up and use elsewhere? Because we often hear, when we're talking about improving care in England, about, well, can we translate this from one area to another? What's your experience of that?
You can translate part of it, but there's a process that's really important to go through, and the process is actually building the relationships within any health system between primary care clinicians and their secondary counterparts. And just picking up something from another health system and dropping it into another one, it doesn't work, because actually the relationships do need to form. What it does mean, though, is that actually we started in Canterbury with a blank sheet of paper. With the 900-odd health pathways that exist now, a number of other systems are able to pick those up, so they don't necessarily need to start with a blank sheet of paper, but they still need to go through the same process, because it's the engagement and the participation that is as important as anything. And I think when we go back to the beginning of the health pathways, we had primary care clinicians really frustrated with their secondary care counterparts, the secondary care clinicians really frustrated with their primary care counterparts, and no agreement actually about how to manage care. And so part of that was also the beginning part of being able for clinicians to let go previous history, where in health, sometimes our grievances, they are our most prized possessions. And every time you start a conversation, too often the baggage from yesterday comes into creating the future. And so the creation of engagement was a way to enable people to at least park or let some of the history go and start focusing on actually how together we might shape and make this work for our system. So that's probably the most important part of actually the creation of the health pathways. Pathways, guidelines, they've existed in health for many, many years. But unless they are relevant and unless there is a sense of ownership to them, they don't work. And so that's been a really important part of that journey. So the West Coast District Health Board now has got health pathways embedded. A number of other district health boards have, but all of them have had to go through a similar journey. And the only advantage they've had is they've not necessarily had to start with a blank sheet of paper. There's some reference points and a bit of it being able to look somewhere and say we can touch and feel how it's worked, and perhaps understanding why it's worked in a particular context.
And Colin, I just want to come to you. So David mentioned there about thinking about the future, designing the future through engaging with different groups. I imagine at Orion you spend a lot of time thinking about the future and how you can work differently. What do you think about, is there much engagement going on between software developers, parts of the health system?
Yeah, I mean, I think increasingly actually, and certainly in Canterbury we've got some of our developers who are embedded in the system, who have a task to understand much more what it's like, how information is used to deliver care, so that understanding can come back into the software. So I think we're seeing much more innovation, and you know, David talks about shared purpose. I think shared purpose needs a shared record as well, and it's one of the key ingredients that I think Canterbury established and as a foundation of transforming the health system, is to say there's lots of useful data points out there, but they were previously siloed. How can we bring them together so that if you're transforming the system, wherever someone might turn up for an episode of care, the information is integrated. So I think once you've got the information integrated, you can start to reason against it. You can start to do much more powerful things. So yeah, we're seeing much more innovation, but it needs that foundation of building the shared record. I think Canterbury's Health One project delivered that really well.
That's great, and I can see we've got lots of questions coming in already about your shared record, which is obviously of interest to us here as we look to develop something similar. Vince, can you tell us about how you got to where you are now in terms of having a shared care record and what it can do for you?
Yes, I mean, they're really important points that Colin makes. That I think we all understand that shared health information is the right thing to do. But sometimes you need a trigger to actually take you across the line. So from a cognitive perspective, yes, of course it makes sense, but actually how are you going to make it happen? And for us in Canterbury, our natural disaster really brought it to prominence, where we realised that people scattered across the system after our earthquakes in 2010 and 2011. And we realised that people were displaced, information was displaced because it was held in silos in either general practices or pharmacies or community nursing agencies. And very quickly after that, we got together with our Ryan colleagues and the District Health Board and said, we've got to do something different, we've got to do something better, we've got to be able to have relevant health information at the point of care for people, and it needs to be foolproof. It needs to be able to work through a natural disaster. So that was the trigger point for us that started that process off, and we all naively and aspirationally hoped this was going to be a 6-week sort of no development project because the idea was sensible and we realised we had the technology and we could put it all together. That wasn't the case, but actually it was about 12 to 18 months. But what we recognised that this was a significant change management process. Technology actually wasn't the constraint. It was people feeling comfortable with sharing health information. It was trying to understand what is the health information that would be relevant for healthcare. And then, very much now the process is, well, what can you do now that you've got the shared information? You can use it for more things than just direct healthcare. You can think about planning and supporting. So we're going on that journey. But the change management process was about getting people to feel comfortable, about trust and confidence that not the health information is just available at the point of care, but it's going to be used for the right purposes.
And I imagine some of that was around getting staff, clinicians to feel comfortable with that. But what about your community, your population whose records it is that are being shared? How did you come to a point where they felt comfortable with that sharing going on, David?
So we've actually got a large consumer council that sits across the system, and so we had them part of the development of Health One. And there's a lot of debate and conversation whether you would have an opt-on or opt-off process with, with the Health One process. And actually the community fronted the conversation about why it was important and why an opt-off was actually a far more important process or step to go through. So part of that is we've got much more comfortable working with our community and actually our community taking leadership roles in terms of actually explaining to the community why this is a really important thing to do. The other bit is we engaged extensively with the community, helping, kind of explaining what Health One was about, and also the opportunity if anyone wanted to have their record turned off, either fully or partially, they absolutely could do that. But what we did encourage them to do in that situation was to have an appointment with their general practice team so that they were making also an informed decision, but that we would honour their choice and decision and not put that or push that down their throat. In terms of the general practice teams and across the hospital part, when you start also hearing clinicians saying this was the best invention since the stethoscope, you kind of start understanding the significance and how much impact that has had. But I think most importantly, there's a sense of ownership both from the clinical community and our broader community that actually this is their health record, and we've now increasingly become the guardians of the health record as opposed to sometimes seeing ourselves as the owner of the health record. And so that's really shifted subtly the ownership right back to you as the individual citizen. This is your health record, and all we are is making sure that we're keeping it safe and using it in the most appropriate way to support you.
Colin, are you seeing anything similar going on in the UK?
Yeah. I mean, I think the whole approach to how you engage the community and what's the right model for opt-in, opt-out, and the way consent guidelines have to work. It's there's a huge amount of emphasis and focus on that. What we have seen is in cases where people have, well, first of all, most people think all this data is shared anyway. A lot of the community get really shocked because they think that this is what's happening normally. Where we have seen opt-out situations, what we've found is that when there's an episode of care that warrants the data, people quickly opt back in. But I think it's people are very nervous. There's an awful lot of nervousness generally about data use and consent, and there's a lack of understanding and education, and that's where I think having a blueprint or a reference model from regions that have been through this and have done it before and can help organisations and regions understand how they engage the community. I think that's what people are after. They just want that confidence of seeing someone that's been through it. And that's why I think Canterbury coming over and going round the regions in the UK has been really powerful.
Yeah, I think it's, you've got to try and, you've got to build trust over time, but sometimes you've got to put mechanisms in place that will help trust get built. And so part of this program is a purpose and use matrix. So it's very clear about what your role is in the system, about what actually amount of information you can get access to. So pharmacists may get less access than hospital clinicians as community nursing agencies. So, and that's been worked through with citizens and with the health professionals. So that's a technology solution to help build trust and remove the risk of people feeling like their health record is going to get misused.
And I'm getting lots of questions through around social care in particular. So we talked about one system, one budget in Canterbury. How far does that extend, David? Does that include social care in Canterbury, or is it something separate?
So it includes part of the social care. So within our health system, aged residential care services, for instance, the District Health Board is the main funder of that. Home-based care support is actually provided by a mixture of multinational, for-profit and not-for-profit organisations. And so we've got elements of that. We've also got a number of other ministries that are responsible for kind of funding relative to children and support mechanisms, social workers, sometimes sitting outside of health. So we do have a lot of interfaces with our Ministry of Social Development, police, education, and increasingly a lot more joint work happening between those agencies. But in our context, and it's a wee bit different in the British one, where councils have overt responsibility for what we would call our aged residential care or home-based support, that does sit within our health framework.
So you don't have that divide that we have here?
We have a different divide. They're all privately run. Again, multinationals, for-profits, not-for-profits, they have all their own different drivers. And while we fund actually if someone is placed in there, we don't have a choice not to pay it. So our role then becomes one of influencing, of actually how do we work with the sector, because quite frankly, if we don't, that can become an area where we just continue to burn a lot of money that kind of into putting people into institutions as opposed to how we might better use that funding in other parts of the health system.
And we're getting a few questions through, Vince, around, so you say one system, one budget, but you're not really one system, one budget. There are still organisations within that. How have you overcome some of the sort of practical challenges for individual organisations that might encourage them to remain operating as silos? So some of the financial incentives, some of the performance incentives that we have here in the UK and are often seen as barriers to working more as a system.
Yeah, so we've talked a bit in the last 2 or 3 days with our colleagues here in the UK about our alliancing framework, which was really an opportunity to recognise that organisations, silos and professions can get in the way of good healthcare at times. As much as they deliver good individual healthcare, they can get in the way of population healthcare. And so part of the process was for us to create an opportunity for clinical leaders to come together in a place that's quite neutral, so outside of their organisation, outside of their profession, to develop pathways for individual patients, for populations of people, and we call it our alliancing. And so I quaintly call it the Switzerland of the system that we've created. So you come out of your organisation, you come out of your professional boundary, and you focus your attention to our metaphorical patient, which is Agnes. Every health system has one, and that's the person who, and so you start thinking, what is there that we can do better for Agnes? And then the Alliance is a place where we design the pathway. The funders are part of that process, so they're watching all the time, they're feeding in about the reality of what funds are available. And the Alliance leadership team, which is chaired by an independent, who's an ex-High Court judge and very good in that role of actually managing the different professionalisms and the barriers of the system. They oversee and they agree what that pathway is going to be, and the funder will mostly go away and fund that pathway. But then the organisations will go back to their places to deliver that service.
So the organisational structures still sit there, but the Alliance sits on top of it and sort of knits it all together?
Yep, absolutely. Yep.
I think it's important that the Alliance is a virtual framework. It's not an entity, and that's been really, really important. And as Vince was touching on, it's very much, it is clinician-led and management or organisation enabled. And again, often in health systems, the funder is the one that sits there leading a lot of those conversations. In this, and what we found early on in the piece is that when we try to change things, the things that all parties come with is normally contracts and funding. And then you're trying to talk about change. And contracts and funding give you all the reasons why you can't do things. And so we've tended to increasingly not have those as part of the original conversations in terms of saying, how would we do this and design this in a way with the funder in the room coming from a basis of how to enable and to support, not to second guess and to sit there and say no, but actually how to use the funding mechanisms that we've got to bring to life what is best for the patient. We still work within the same rules, regulations, national contracts as the rest of the country. And so what we just changed our mindset is how do we use those frameworks to enable us to do what we need to do, as opposed to using them as a reason for not doing.
So you're starting with the care model for the patient, what the right thing is to do, and the technical aspects of the funding and the governance, etc., follow behind that to support the right thing.
Yeah, and the Alliance doesn't have the ability to actually commit funds, but actually in their thinking they know the constraints. So when they're thinking and re-envisaging what and how things might happen, they understand that actually there is a finite set of resource. And again, it's that role of the funder working with to look at how do we use existing mechanisms to to bring something to life, how we might shift some investment from somewhere else in a system to support or enable whatever is coming through from there.
And just moving back, Colin, to some of the details around the shared care record, because I can see we've got lots of interest in that from our audience. We're being asked, did all the organisations in Canterbury have to change the system they were working with? Did they have to move on to a different system? Or was the care record, did it work around what was already there?
Yeah, so organisations have their existing systems, but there will be lots of useful information that exists out with them. So I guess the principle of the shared care record is it sits across them, and so it almost gives the best holistic view of the information you might need to complete an informed episode of care. One of the things that's key is speed of access. So primary care tend to have quite rich systems themselves anyway, but there's information that's available that's not within that system. So they just want a quick click of a button access to jump into a shared care record, see what they need to see, and then back into the system they might work with. So all those existing systems still exist and still have a use, but the shared care record has a sort of system-wide purpose.
Yes, so basically what it does is it uplifts information out of those primary care record, pharmacy record, community nursing record, and lifts it up and available. And then the community system can then look through that into the hospital system. And that's a lot of the Orion structure is in the hospital system, and then they connect that back to the data lake effectively of the information out of primary care. So that's sort of the technical construction of it. It's about as far as my technical capabilities can go. That's the way I see it. Yeah. That you don't have to rebuild a hospital system because you use the existing one, but you are uplifting relevant health information out of those primary care records and making them visible.
And we're having some questions come through as well around prevention, population health management. So now you've got all that data, all that information brought together through your record. What can you do with that, Vince, in terms of using that to improve the way you manage the health of the population? Yeah,
so at the moment in primary care, that's still very much just within the primary care record. We're about to embark on a conversation now about what the opportunities are that Health One's been created, but we haven't had that conversation around using that as a population health tool yet with our primary care providers and our secondary care providers. So that's the conversation we're embarking on now, because as I touched on earlier, that is the opportunity that's in front of us. But effectively, people will manage population health. We will manage it within our network. But that's not good enough. That's not enough of the information. You've got to be able to join it together with those other systems. So. And
Colin, I just want to come back to you. What do you think the role is of software developers, technology developers, in terms of moving towards a more population health focused approach? What can you bring to the table?
Yeah, so I mean, again, I think the foundations of population health are around building the shared care record to start with. So you need to bring the data that's out there is in all sorts of different formats and all sorts of different places. So we call it the 7 A's towards population health management, actually, and there's no way of really bypassing it from a technology perspective. So it's the acquisition of data from wherever it's held. It's the aggregation of data, so you bring it into a large data lake. It's the access of data, so that you're making it available to people. There's the analysis of that data, so that you can reason against it. Can we spot opportunities where people could be, which population should we focus in on because we'll benefit from that? There's acting, which is then enrolling people on a managed care programme or putting people on a care pathway, and then adapting that situation based on how people are performing and looking at outcomes. And if that's working, you'll get the adoption of the system. So we say that this is 7 A's towards population health management. You could call it the viewing, the chewing, and the doing, I guess, is how we like. And then if you get into the more innovative stuff with genomics, I've suggested that should be the Ewing, but nobody's they're not that happy about that so far internally. But so it's a maturity journey. You can't bypass it. Aggregate the data and then you can reason against it. I think people are aiming for that, but many are still putting the foundations in place.
And David, we're coming towards winter here, which means everyone's thinking about flu. I think you're just coming out of winter and you've just had flu. Did that sort of data you held, that sort of shared system approach, did that help you manage that sort of population level concern?
Yes, it has, because sitting underneath that, because with the integrated approach we've got, you're 30% less likely to be admitted medically unwell into a hospital in Canterbury compared with the average of New Zealand. In terms of primary care, with the access to all of the tools and mechanisms, they don't need to now refer to a hospital for a whole range of either diagnostics and or arranging care to keep people well in their own home. So general practice have now got the availability and the access to all of that, and we've got the funding mechanisms to support that. It works in a high trust environment, but comes from the basis that primary care does everything it can do to keep someone in a community and a supported one. So if they need to arrange a support package to be in this afternoon to keep someone in, kind of in their own home, that's activated, kind of immediately. So the power of when you get one of the mantras we've got is you need a whole system to work for a whole system to work. You can't just fix one part of a system and kind of think it's going to magically impact somewhere else. You've got to have all of that in balance. So what we've now got is less people going into hospital. What it does mean that general practice and the hospital-based part and our community providers now see it as a failure if we're having to cancel planned care into a hospital. So everyone in the system has now become a stakeholder to make sure that actually we will do whatever it takes to ensure that we do not kind of cancel planned care. And actually through one of the busiest and heaviest winters that we've had for many years, we've only cancelled one planned care patient, and that was a cardiothoracic case that the same team ended up operating 2 days later in a private setting on the basis of that was where the capacity was sitting in the system.
So you're starting to see some real results in terms of how the whole system can work together to tackle those issues as they arise in real time.
Absolutely, and it means that you start thinking about capacity quite differently in a system. General practice has a huge amount of ability to change and influence care if it's got the right tools, the access and the support mechanisms to be in place. Our ambulance provider, we've brought them in as part of the care team, so they're no longer a transporter, they're part of the front line. So COPD, for instance, 4 years ago, we had about 8,000 kind of bed days a year filled with COPD patients. This last year it's just over 4,000. So we've almost had about 50% of people with COPD are now being managed in a community setting. So when an ambulance is called to a home, we've got agreed protocols in terms of actually with certain criteria, the individual will stay in the home so the ambulance won't take them anywhere else. Or if there are certain other criteria, they'll be taken to their general practice. And if that general practice is busy and unable to take them, the ambulance then is referred on to the 24-hour surgery, which is a 24-hour general practice part of our system. And then if there's very complex kind of COPD patients, they're directed directly to the hospital. So what we've now got is a system where it's clearer about where and what is the right place for a patient or an individual to be receiving their care. And it's increasingly now become less about organisations. It's actually where is the right place for an individual to be able to access their care. And when you do that, you suddenly realise you've got a whole lot of capacity in a system. You start reducing all the churn, all the shifting a patient from this part to that part of a system. And that's where we've kind of got to, is a system that's able to shift and change actually during a day to deal with different pressures and loads. So if the hospital is under real pressure today, and again through the use of health pathways and the connections into primary care starts adjusting the way that it's operating, and will pick up a far more acute load in the primary care setting. So we've got this live system that's shifting and changing on a regular basis.
And Vince, we've been asked here what's been the role of patients in that engagement process. So maybe sticking with David's example of the COPD, the changes in that pathway, was that based around what patients said they wanted? Did you involve them in that process? How did you get to the point of the model that's there now?
Yeah, very much. I mean, we've had an integrated respiratory program now for about 6 or 7 years, and it's more around sort of cardiopulmonary rehabilitation in the community. But it was those communities of patients that were saying to us, we think we're unnecessarily being picked up and go to hospital. We need other options of care. And so really that information came out of those groups. And those groups are enduring now. They started off with quite a bit of therapy and community support. There's 2 or 3 of those groups now have maintained themselves, and they have coffee groups on a weekly basis. But it was those people that said to us, actually, we need different options for care. And when we looked at the data and looked at our hospital data, realising that in New Zealand, internationally, we're an outlier on how we used, how COPD patients use hospital beds. So those things came together. Good use of data, good use of information, patients saying they want a better service. They felt like they had permission to ask us for that, and that's how the program that David just talked about started.
And lots of questions coming through about community engagement, but particularly some, David, around where do you start? So how did you've got now some structures in place to work with your population, to work with your communities, to work with your clinicians, but what's the starting point to get there?
The starting point was actually a number of key leaders across what was starting to emerge as a Canterbury health system, as opposed to a lot of disparate parts, starting to describe what were the key characteristics of actually an integrated health system. And one of the challenges we had there is, how do you get everyone that works in our system having a sense of being part of creating that? So we've approached this in a number of different ways, where we've had a number of events that we've called Showcase, where we've had thousands of our community and clinical teams through a series of events that have enabled them to feel as though they're part of and are creating a shared sense of purpose and direction. So the biggest part was actually us starting to realise that actually communities are really powerful to have in the room, and getting both clinicians and communities starting to focus on actually what are the real issues that we're facing. It's amazing what is able to come out of that. So we've also got, we use the community with advanced care planning at the moment. It's the community having the conversation with itself, not clinicians, not organisations talking about end-of-life care. It's actually our Consumer Council actually having that conversation with the community about why it matters. And so a lot of this has been about actually helping give meaning and understanding why and how a system might work, because we often think people understand it, and we always continue to keep on talking at communities. And so we've started to get much better at hearing and listening and being able to give it a sense of why this might be important, not actually we've got the most brilliant idea and solution and this is what we're going to do. So we've tried to move away from the word consultation, because actually consultation has come to mean quite a kind of an ugly connotations. Is that actually you've got a great idea, you're consulting with the community, and you might take on board a wee bit of what they've got, but you've pretty much decided what you're going to do. So we spend a lot more time with engagement and getting the communities involved early on in the conversations. And some of the designing and shaping of how services might happen. It's very rare for us now not to have a patient, a citizen or a consumer as part of the design process.
And Colin, what about for you? Is there something that you can learn from the people using your products, whether that be the patients involved, the communities involved, or the clinicians that are using them? Can you engage with people?
Yeah, I mean, I think one of the big topics in our space generally is patient access generally, and giving individuals access to their own record, and that's been quite an interesting experience actually. We've a little bit surprising in terms of the reality of the reaction, because there was all the barriers that we thought we would have to people having access to the record, and people expressing concerns about not everyone has access to the sorts of technology or computers or mobile phones or whatever that would give them access to the records. But we've got quite a lot of instances where, one example, a couple of elderly patients, when the consultant was having a chat to them saying it would be good for you to have access to your own record, and they pulled out their old Nokia mobile phone saying, well, this isn't going to work, this isn't going to fit the bill, and at their own expense went out and bought iPhones. So I think what we're seeing is that that was surprising for us, because that isn't what the naysayers had led us to believe would happen. So I think what we're seeing is that people have got an appetite to get more involved in their care at the moment. I think technology's got a real key role in making the data available so that they can become participants. And then as we've looked at these shared care records building, I mean, there's these big community events, I think, where the regions, invite their community to come and understand what's going on and to express their concerns and things like that. And you can see the programmes that are going to work and the programmes that aren't. The ones that are going to work, the rooms are packed, it's standing room only. Occasionally you'll walk into a room that's quite quiet and you think something's gone wrong here. So
we've written quite a lot at the King's Fund about the process of developing sustainability and transformation plans and partnerships, and perhaps that communities haven't been involved as much as they could have been, but it sounds, speaking to all of you, like there's lots of opportunities and benefits that can be gained if places really start to invest in their communities and bring them into the process.
If you've got a plan that's owned just by leaders in a system that's got no connection to those providing care or the communities, it's less likely those plans will ever come to life. And so there is an element of how do you get that bled through an organisation or organisations? How do you have that where a community has a sense of ownership? And I think that's a bit that often health systems don't pay enough attention to, and then put some artificial timelines that actually this has to be delivered next year or the year after. And so what that starts to do is perpetuate using yesterday's tools and approaches to be trying to solve tomorrow's problems. And inadvertently with that we create a lot of churn and not a lot changes. And yet sometimes there's the most brilliant plan that's sitting there, but no one understands it. There isn't a meaning or a purpose. And I think one of the things and one of the challenges for, I think increasingly for health leaders, is actually being able to articulate and give meaning and simplify why this matters, and kind of why you're an important part of helping us solve that, and how are we going to change the system, as opposed to how is Vince going to change it, or how is Colin going to impact on that, or how this organisation's going to do its bit. Again, increasingly, how are we going to kind of change?
Yeah, if you look at that future, I just wonder what it means for healthcare. You look at that future of the driverless car. So no one's behind the steering wheel, but everybody's in that car together. And what does that mean for healthcare? That it shifts that locus of control, that actually the patient becomes a significant player in their healthcare. And so what does that mean for clinicians, and what does that mean for administrators and planners and supporters of the healthcare system? And so I think that's a real, I just sort of developing thinking about the metaphor of the autonomous vehicle, because it just shifts that locus. And so therefore we've got to provide more information. And I personally don't think the constraint is patients or communities. It's the system, as us, it's how we think about sharing health information and doing those things. And we were talking about that before. Technology is not the constraint. the performance constraints, the behaviour and the way we work in our models of care. That's the constraint, and that's the work that we have to do with the health system.
And we've had a few questions come through around the workforce, so the people working in the Canterbury health system. So we know here that we've got lots of concerns around workforce, particularly, for example, around primary care, so trying to recruit more GPs. What sort of impact, Vince, has the models you've had for the experience of people working in the system? Has it affected how well you're able to go out and recruit people, how long people are staying working in the system?
Yeah, so it's been a bit of an embarrassment when I've been talking to some of your colleagues here in the UK when they are really struggling to recruit the conventional healthcare team, GPs, nurses, and nursing assistants and those things. In Canterbury, we're not at this point in time got a lot of those difficulties. We're managing to encourage general practice, but we looked 7 or 8 to 10 years ago about where was the workforce going and what was that going to mean. So we got ourselves involved in the undergrad program in nursing to start creating a momentum and an experience in general practice. And we've got a stage now where we've got a waiting list, quite a significant one for people, for nurses wanting to come into primary care. We've increased our registrar training program from 8 or 10 a year to 30. So we've kept on tap those roles, but the real challenge for us then is going to be, is that truly the workforce of the future, or how we're training them at the moment? I had a very interesting conversation with some of your colleagues around the table a couple of evenings ago about our training programs are still training people to deliver today's medicine. And actually we need to think about tomorrow's healthcare. I think that's a real challenge for all of us. And in Canterbury, we understand it, we are thinking about it, but have we done anything dramatic in that way? No, not yet.
I've had quite a big question here, but let's see if you can answer it, having spent a few days talking to various people in the NHS. We've been asked, is this kind of integrated system possible in the NHS, given all the national frameworks and regulation and complication that we have here? David, yeah. I'll give that big one to you.
Yes, it is. And I will put a bit of our New Zealand context into play there. I could look you straight in the face and give you every reason why we could not or should not have done everything we've done in Canterbury in the last 7, 8 years. And I can also look you straight in the face and say there's actually nothing that got in the way of us doing that. And I think at times, health systems, we can overcomplicate things and sometimes sit behind and using rules and regulations as a justification for not starting, as opposed to how do we start understanding the constraints and the mechanisms we've got to start working for and enabling the change that does need to happen. So I think one of the biggest challenges, I think, is starting to frame the basis of how do we make this happen. We still have to operate in the same rules, regulations, national contracts, that exist. But by getting the engagement right and the various parties with a common sense of purpose, we've been able to make sure that we do use the frameworks that we've got. The NHS certainly has the sense of being incredibly complex. And I think part of that too is the sense of how do you get regulators, commissioners and providers getting much more of a shared sense of purpose and alignment of what they're all collectively trying to do. And it's not an easy pathway, but actually the beginning parts of getting those parties together and starting to have the conversations and starting to get a shared sense of purpose, until that's becomes a wee bit more of the normal, the challenge of actually making the real changes is always going to be problematic. And I do think one of the challenges too is how health systems, and it seems to be one of the reflections with the UK, you've got these impossible timelines where massive change is needing to be delivered by. And sometimes that can get in the way of actually getting the shared conversations, the shared sense of purpose, and spending a bit more time of doing that. Because if you get that right, you can make those bigger shifts far quicker at some point. So it's there's certainly some unique challenges in the NHS. I know one of the reflections that Vince and I had over the last couple of days is we didn't think the NHS could have got more complicated. And there's a whole new set of acronyms and other bits that have kind of really emerged in the last couple of years. And that does make it easy for people to get lost in the complexity, as opposed to how do we collectively simplify it to make sense for those that actually work in health. Because actually there's some brilliant people over here.
So to keep in mind the aim, the objective of all of that in terms of improving care for the population and not get too caught up in the detail of it.
And it's one of the things, kind of reflection is how often money and finance is at the forefront of the conversations here, as opposed to what is the right thing to be doing with the community and how best to organise that. And that's, again, we still have that same challenge in our health system too, in terms of constraint. But how do we change the story or change the way that we're articulating, instead of seeing it as this is why we can't do things. Yes, we know there's a constraint, but actually how are we going to kind of bring this to life, recognising that there is limited resource in the system.
And Colin, we've had a sort of related question around how do we adopt transformational digital change, so not just tweaking around the edges but doing something really different. Do our structures stand in the way in that? How can we get there?
I think there's been quite a lot of good progress made, actually, but again, it's about building the foundations. I think you can only get so far with building a shared care record when you've got an awful lot of other complexities to sort out with the way the NHS is structured. But I mean, down in the southwest with the Connecting Care programme, the CIDR programme in Camden, the activity down in West Kent, the Care Coordination Centre up in Trafford, just examples of regions that have came together and have recognised that they need to agree how to share data, establish a record, start to think about the populations they want to manage. I mean, I think the workforce transformation and all the things that Canterbury have done, I guess there's still a way forward for all of that to happen, and I don't quite know how all of the contractual complexities would get sorted out, but I certainly think there's positive momentum. So once you've got those foundations, though, and you've got the data together, there's a lot of opportunity for transformation. But I don't think it's going to be particularly quick. I think there's still need to. I think over the next couple of years, you'll still see regions simply putting foundations in place and speaking with regions like Canterbury to understand how do we set ourselves up for everything else that has to happen, because we now have a technology answer. So I don't know if that really answers the question. There's pockets of innovation that are running in parallel, I would say, as well. So you've almost got an operational system. We're starting to see people put in almost an innovation platform, so a digital platform that can surface data for trying out new apps and things like that. So they're almost running side by side in some cases, and the world will end up with the new fancy innovative tech, but it's slow steps with single use cases.
Yeah, and David and Vince, I know we've spent quite a lot of time talking to various areas of the country this week, and we've heard about some really exciting progress. There's certainly lots going on, and I think something we've heard from you time and time again is it's an evolution, it's a journey, it's not one big leap to get to where you are now. Another element of the questions that are coming in are about how we think about, or how you've thought about in Canterbury, the wider determinants of health, so housing, education, sort of wider things that factor in. Vince, is there anything you can tell us about what you've done there? Yeah,
so we've applied our mind to that quite a bit, because there's a recognition and that the healthcare system can become a real silo. And I think David just talked before about the relationship we've got with police and corrections and our justice system and our social welfare system. And so we've got a number of programs that are beginning to look at that. But then we've understand in our communities warm housing, diet, education, and we run green prescription programs. So we're beginning to look at all those other determinants earlier in the piece, so trying to work with communities around what's happening with our children. We have a program in New Zealand called the Before School Check program, so every child in their fourth year, in year 4, gets a check which actually begins to understand how well have they progressed from 0 to 4. And that's starting to give us a nice picture about the things that we need to be putting in place around childhood obesity and some of the delayed developments. So we're going to look at those, and then of course that's taking you back to the family and taking you back to the community, understanding what's contributing to those cases that we see. So some of the programs I said before are warm housing. We were understanding when we're looking at a lot of our COPD patients, the recognition that of the housing stock in Canterbury was poor. So we've had a program in place to actually be able to insulate homes. So there's programs like that. They were one-off programs that are doing very well, but they weren't connected to the whole system. So what we're managing to do now is actually try and make a real connection with our population health program.
I think when we come back to the vision of the Canterbury health system, it's the home that sits in the middle or the centre of it. And actually, most people start and finish their life in a home, and kind of their own home. So health has got to start thinking beyond its traditional narrow borders, as Vince was touching on. So our work with police, for instance, so often they're in the house in the first instance with call-outs. Increasingly, the police in Canterbury are becoming much more of the trigger point for a lot of the referrals into the health and social sector, instead of kind of arresting and we're starting to pilot some quite different ways of actually the police being actually an integral part of a health workforce in terms of how that happens. The work with education, we work with councils in terms of health impact assessments on kind of new developments. And with all of our councils and regulatory agencies, we've now got shared what we call a health and all policies framework, so that health is now starting to weave its way through. So when we look at alcohol, for instance, the councils who license or provide the liquor licences, police, health, have now got a shared strategic plan. And that's been an important part of actually how we collectively have a voice with the alcohol industry and start to change the conversation and the nature of the conversation coming from a wellbeing framework as opposed to either health doing its bit and councils doing their bit in isolation, and then the police being required to enforce. So what we've now got increasingly is all of those agencies with shared strategic directions and also much greater understanding and agreement about what the parts each of those players have in doing that. So we're now speaking much more consistently, and that's starting to give communities a voice that they didn't have before.
Back to your point of the shared aim, all having one vision, one aim.
Yeah, and everything comes back to that in terms of actually a shared sense of purpose of what collectively we're all trying to do, and that ultimately is to help people live the best possible lives in their own home, neighbourhoods and environments.
And we're running low on time, but I think we've got time for one last question. So I've been asked, if you were going to start from scratch, start again, what's the first thing you would do, Vince?
Oh, damn. Engage your communities, engage your clinicians. And I think the point that might have got sort of skipped over before when David talked about we're a connected system aiming not to waste people's time. It's people, so people are also providers, and I think it's because it's damn hard out there. Our hospitals and our primary care clinicians, our community clinicians are working really hard, so the system's got to orientate itself around to not wasting the patients, not wasting the people's time, which is patients and providers. But it's that engagement process and starting a conversation. Get in a room, have a conversation, how can we do this better?
And David, what about for you?
And very much the same thing as getting all of the different parties together, starting to have a different conversation, and with people at the centre of all the conversations, not the organisations, not all of the contracts and the funding issues that are there, actually people. And it is one of the things often in health we forget that kind of people are always people. Patients are also people, and they're only patients part of the time. And we've got to continue to think about actually how do we engage with communities, but also recognising that then those that work in the health system are also people. And when you get the engagement right, you really get the very, very best out of a system.
Great. And Colin, maybe a slightly different question for you, because you're not starting again in Canterbury, but what will be your sort of main takeaway message from their journey?
Well, I would say irrespective of the region or the system, you're going to need a shared care record, and people should press on with confidence, because none of this is possible without that. It's not the only part of the answer, I think, as we've heard. There's many other aspects of it, but that shared care record is going to be a foundation of transformation, and serves as the platform for system-wide access, for innovation, for population health management. So it's not a bad thing to focus on and to crack on with, even if you've not figured everything out.
It sounds like you've got to take people along with you on that journey together.
But it's also a catalyst for the journey, because it will open up the conversations of sharing data, and it will open up the conversations of, well, who needs to share data, and it will put different stakeholders in a room together to discuss things, and they'll start learning things about each other, and that's part of the process. So it's not a bad catalyst either. So the technology guy's always going to say build the technology.
But it seems the other guys are agreeing with you too. So. Great. Well, we're out of time, but thank you all for joining us, Colin, David, Vince. That's been great. Thank you, everybody at home, for joining us and sending in your questions. There's been some I haven't been able to get to because of time, because we've had lots, but I've tried to cover the main themes. So I hope that was useful for everybody. Thank you for joining us. Thank you again to our guests for joining us, and hope to see you again for the next one.